I'm the Chief of Urology at the University of Texas Health Science Center here at San Antonio. It's my pleasure to spend a few moments of your time on the subject of the diagnosis and detection of urologic neoplasms in the geriatric population. We're going to start with the subject of prostate cancer and prostate cancer early detection and treatment. And if you look at our first, we have some graphics here for you, that prostate cancer is a major polemic in the United States. A lot of controversy. There are many differences in the recommendations of various specialty organizations with regards to its treatment and whether it should be actually screened for. And let's kind of go over some of the recommendations of these organizations. The American Urologic Association and the American Cancer Society recommend offering PSA, which is prostate-specific antigen. It's a blood test, and digital rectal examination to men who are at risk, who are pretty much any man over the age of, with a 10-year or greater life expectancy. And we're talking with a greater than 10-year life expectancy being about the age of 77 or 78 based on U.S. vital statistics. The U.S. Preventative Services Task Force, which writes the manual for preventive services, do not recommend even offering a rectal examination or a PSA. And some of the concerns, we're going to go through the concerns and then the rationale supporting it, as well as some final conclusions. There are some concerns from skeptics about the screening for prostate cancer. This graphic that you see here illustrates the background rate of autopsy tumors. This is from Weil Sacker, who's a pathologist at Wayne State University in Detroit, who worked with the medical examiner and looked at prostate specimens in men who died of other causes, trauma, car accidents, and so forth. And if you look, the background rate of prostatic intraepithelial neoplasia, which is a possibly pre-malignant lesion, but more importantly, the orange or red bars on your screen show that there is a tremendous background rate of prostate cancer in the population, and it actually goes up so that your lifetime risk of actually having histologic evidence of prostate cancer is probably in the 70% range or so. And so skeptics will say, well, certainly the risk of dying from prostate cancer is nowhere close to 70%. For that reason, we should not be screening for it. Additionally, if you look at this is a fairly complicated graphic, but it illustrates the concern of something called length-time bias. And I've illustrated four patients here, patients A, B, C, and D. On the left axis, the y-axis, you see gradual increase in growth of prostate cancer from where it develops in a very small focus to where it's detectable, say for example a PSA that's greater than 4, to a point that it spreads beyond the prostate, to spread into the lymph nodes, to metastatic disease, and ultimately to death from the disease. And over the time being the x-axis, and you see multiple, perhaps annual examinations with PSA and rectal examination, you have the opportunity to detect the disease. And so this yellow or orange band that you see here is really the region where you can detect it and before the point in time when it's no longer curable. So let's look at patients A, B, C, and D. Well, patient A actually develops it early on in the course, but never develops disease that is detectable and dies of something else. So in this patient, no benefit, no loss, no problem. Patient B is kind of an interesting character because about the 5th iteration of his PSA and rectal examination, one or the other is abnormal and is found to have the disease, but unfortunately, ultimately would have died of something else and thus has the anxiety and potential treatment which was unnecessary from prostate cancer. So skeptics would say patient B benefits not at all. Patient C, on the other hand, stands to benefit because on his 3rd examination, as you see here, there is an elevated PSA. And the elevated PSA prompts a diagnosis, prompts an intervention, and this patient was ultimately destined to die of his disease. So early detection and diagnosis made a difference in patient C. Then there is this patient D, an interesting individual whose first visit, no detection, second visit, PSA is not high enough, but by the time his 3rd visit comes around, the prostate cancer is outside the prostate. And so early detection did not help this individual. In fact, screening tends to find tumors that are more slowly growing. So of patients A, B, C, and D, only patient C stands to benefit. There's also a concern about cost from early detection. Our initial estimates for screening for men ages 50 to 70, which we published several years ago, suggested that it was going to cost about $25 billion during the first year alone. morbidity, certainly anxiety over the diagnosis, risk of the biopsy, which is pretty low, but it's uncomfortable, bleeding and infection are unlikely but possible complications, and certainly there are the risks of treatment to include sexual problems, urinary problems, damage to other adjacent organs and so forth, and finally a lack of proven efficacy. We certainly know that there are ongoing 2 trials, one in the United States called the PLCO, that's actually randomizing 148,000 men and women to screening for prostate, lung, colorectal, and ovarian cancer. And that's currently going on in the United States. And we should know the results in some 10 years or so. And the European Rotterdam trial is also ongoing. But again, we're not going to receive the results for another decade or so, perhaps at the earliest. Now, there is some evidence of effectiveness of screening. First off, it's pretty clear to most people who deal with prostate cancer that we're not finding these autopsy tumors. Autopsy tumors tend to be microscopic disease. And if you look at patients, for example, who are diagnosed and undergo radical prostatectomy, and Dugan and his colleagues from the West Coast did an analysis of looking at doubling times of PSA and the volume of the disease and estimating whether the tumor was clinically significant or not. And when they looked at it and they assumed the worst case doubling time, being the slowest growing tumor of 6 years per doubling in PSA, the percent of insignificant tumors was about 15%, suggesting that 85% of tumors were clinically significant. If you actually assume more reasonable doubling times of, say, 4 years or so, it means that 9 tumors out of 10 are potentially clinically significant, and maybe even more than that. Also, kind of an interesting analysis with regards to cost. Remember I told you earlier that $25 billion per year is the cost of screening, but then if you put it in perspective and you determine what's the likelihood that the cost improves life expectancy, more importantly than that, quality life expectancy. And this is an analysis of many published series, including one of our own, that looks at the cost per quality adjusted life year gained. That means if I spend X number of dollars, how many additional years of life do I stand to gain? And those years of life have to be perfect quality. Liver transplantation, $250,000. Screening mammography for women under 50, about $250,000 per additional life year gained. Worst case for prostate cancer screening, this is taking all the worst possibilities, about $145,000 per year, additional year of life gained. Best case is about $9,000 per year that you gain. And then if you look at things that have been published in between, a heart bypass, a coronary artery bypass graft, $106,000. Using cheap drugs for high blood pressure range somewhere between the worst case and best case. The only thing that's clearly better is that we as healthcare providers, if you see a pack of cigarettes in a guy's pocket, tell him to take it away, throw it away. That's the cheapest intervention that you can make. But it's pretty clear here that the cost for prostate cancer screening is somewhere in the usual kinds of services that we provide for our patients. With regards to complications, we reviewed the results of complications from treatment, and certainly the complications from treatment are falling dramatically. We did a reanalysis, as you see here in this graphic, that shows that the rate of complications, for example, with radical prostatectomy, continued to fall dramatically. Sexual complications, urinary complications, and actually the risk of death with radical prostatectomy is now down about 0.2% within 90 days of surgery, which is actually a lower death rate than you see in the general population. And the same is true for radiation therapy, brachytherapy, and so forth. Finally, there's been this natural experiment that has been going on, and that is that a substantial fraction of men in the United States have had their PSA checked and have been screened effectively for prostate cancer. The interesting thing that we've seen is that mortality from prostate cancer has fallen. It's been seen in the surveillance, epidemiology, and end results reporting system of the National Cancer Institute, the SEER system. Seen in Olmsted County, which is where Mayo Clinic is, where a number of men get PSA determinations. It's been seen in Canada and Quebec, in the Department of Defense, and an interesting observation in Tyrol, Austria, where a substantial, about 2/3 of all men were screened beginning about 1990. Interestingly enough, you don't see the fall in other countries that don't screen. Here's the fall in prostate cancer mortality in the United States. Unfortunately and challengingly, The fall is not as much in African American men who are disproportionately affected. Here's the rate of detection of prostate cancer over 15 years. You can see the dotted line indicates about when PSA screening began. You saw an increased number of cases that were detected, and then this is a per population age-adjusted rate of prostate cancer detection. You see it's not much greater than it was before PSA came about. Most importantly, men with prostate cancer die from metastatic disease. And as you can see here, the rate of metastatic disease is falling dramatically to levels that have heretofore never been seen in the United States. So what's the bottom line of early detection? It appears to be doing what it's supposed to do, finding tumors early, tumors that can be cured, and tumors that need to be cured. And the natural experiment of PSA screening appears to be saving lives. So what do we do? Well, we generally recommend that men consider early detection of prostate cancer at the age of 50. Prostate cancer before that age is unusual unless you're at high risk. Here's a graphic from the state of Texas, for example. As you see, the green line indicates African American men, and they are disproportionately affected, almost double the risk of dying from prostate cancer. Although Hispanic men have a lower rate, age-adjusted, nevertheless, it is the most common cancer in Hispanic men and one of the most common causes of death. How to screen? Well, we recommend that you include both PSA and rectal examination because we are seeing an increasingly number of individuals with PSAs that are normal who have prostate cancer, frequently bad prostate cancer. I recently treated a gentleman whose PSA was under 1 who had a very rapid growing prostate cancer that was very fortunately detected because his wife had him come in and have a rectal examination. And about 25% of all cancers are found with rectal examination alone. PSA consistently has some of the best performance characteristics of any screening test. 25% of the time, if the PSA is abnormal, prostate cancer is present. It's also highly predictive of tumor stage. So if it's less than 10 or less than 15, that's all that you need to do if you find that prostate cancer is present. No other staging tests, no CT scan, bone scan, and so forth. If the PSA is less than 2, the other thing is that the man is unlikely to be found to have prostate cancer, and you may be able to, if the rectal examination is normal, see that individual about once every 2 years or so. You can actually age adjust the PSA based on the fact that PSA tends to rise with age. In young men, if you adjust the PSA value down so that you use a lower level than 4 to detect tumors, you increase your sensitivity, find more tumors. In older men, if you increase it up, you result in fewer biopsies and more specificity. Unfortunately, you can't have it both ways, and so what we tend to do is to age adjust for younger men. For example, as you see here, a man in his 40s, his PSA should not exceed 2.5. A man in his 50s, his PSA should not exceed 3.5. But a man in his 70s, we still use a PSA cut point of about 4, because a lot of tumors between 4 and 6.5 will exit the prostate. As you see here, recent studies have found positive biopsies in many men with PSAs between 2.5 and 4. And so in many individuals, actually men even in their 60s, we will consider a prostate biopsy if their PSA exceeds 2.5. Historically, it's kind of interesting how PSA cut point began. A relatively small number of individuals, actually men and women from the West Coast, had PSA determinations, and a PSA of about 4 was determined to be the optimal cut point. We've subsequently found out that's probably incorrect. You can also use something called percent-free PSA. PSA is bound in the serum to some plasma proteins, and as you can see here, if you use the percent-free as a secondary test, you can just check it off as a separate test in your lab slip. You can see if your percent-free PSA is under 10%, there's a dramatic difference in its prediction of prostate cancer. About half of all men will have prostate cancer. PSA greater than 25%, percent-free, greater than 25%, drops down substantially. Now, we don't tend to use it in our first test. We tend to use it in subsequent tests. As you can see here, you can use a complexed PSA, which also improves the sensitivity. Unfortunately, the specificity is reduced. And specificity, again, refers to the likelihood that you can reduce the number of biopsies to increase the number of tumors detected. And specificity with total PSA remains the optimal. If you use percent-free and complex PSA, the specificity falls. There's obviously a trade-off here. The advantage of using percent-free and complex PSA is it eliminates some of the biopsies. The disadvantage is that it misses some of the tumors, about 5 to 10%. So we don't tend to use it up front because we'd rather find the tumors and perhaps use the percent-free in men who have an elevated PSA and who have a negative biopsy, and you're subsequently seeing them later years checking their PSA remains elevated, then consider checking a percent-free PSA, because if the percent-free of PSA is elevated, you might tell that individual, low likelihood of prostate cancer, perhaps we don't need to repeat your prostate biopsy. So with regards to conclusions with regards to screening for prostate cancer, we're probably not finding autopsy tumors. The cost seems to be acceptable. Complications are unusual and decreasing in frequency, and there is evidence that screening is associated with a fall in mortality. With regards to testis tumors, we're going to be moving on to these. I thought I'd just mention it just briefly for a few moments. Testis cancer, although uncommon in geriatrics, does occur, and you have to remember it's a possibility in a man of any age. And testis cancer rates are increasing across the world. Every single tumor registry in the world, the rate is continuing to increase. We've published on this subject with regards to testis tumors in the Department of Defense. This includes not just active duty, but retirees, and you can see testis tumors in older individuals. With regards to detection, the clearest evidence that testis cancer is present is the presence of a palpable testicular mass. It's generally non-painful, and it will be noted by the individuals on routine examination. If you suspect that a testis tumor is present, the optimal way to detect it is with an ultrasound that will show a classic hypoechoic intraparenchymal lesion, as you see here. So just briefly on testis cancer, don't forget that a painless testicular mass in any man of any age has a risk of being a testis cancer and has to be disproven before you proceed to other diagnoses. Let's move on to neoplasms of the kidney and of the bladder. Tumors of the kidney. Most tumors of the kidney are renal cell carcinoma, and a solid mass in the kidney is a renal cell carcinoma till proven otherwise. There are other types of tumors. This is an example of an angiomyolipoma that's benign, but although it's benign and rarely metastasizes, it can bleed spontaneously, as you see here on this CT scan. There are 30,000 new cases of kidney cancer annually, and 10,000 individuals will die from this. It's age-related, so it increases with age, but I've seen a kidney cancer in individuals in their teens. Males predominate. Risk factors, although it says no here, smoking may increase your risk slightly. The main risk factor is if you have a strong family history of kidney cancer. Saw an individual just a few days ago who multiple members of his family had kidney cancer, solid mass, high likelihood of kidney cancer. There's a disease process, VHL, as you see here, is called von Hippel-Lindau disease, and it's associated with a gene on the third chromosome that increases the risk of developing kidney cancer. Fascinating how it actually works. Multiple tumors will occur in these individuals. The cell of origin is the proximal renal tubular cell. And that's why you will see most kidney tumors on the periphery of the kidney. Here on your left side, which is the individual's right kidney, you see this mass appearing off the lateral aspect of the kidney. This individual actually had a kidney tumor. The natural history of kidney cancer is that it spreads through the capsule of the kidney, invades lymphatics, local lymph nodes, distant disease. It can also invade the vein, the renal vein, and propagate up the vena cava and into the heart. And here you see an example on your left, which is the patient's right, is a solid renal mass. And as you can see, that mass extends more medially and actually occupies the cava. The graphic on the left-hand side of your screen shows the mass propagating up the cava. And here we have an ultrasound that shows the thrombus. This is actually living tumor that has propagated up into the atrium of the heart and obviously poses somewhat of a therapeutic challenge. Pain, palpable mass, and hematuria are the classic triad of presentation of kidney tumors, but today they only constitute, thank goodness, 10% of cases. weight loss, and paraneoplastic syndromes can present. For example, hypercalcemia, thrombocytopenia, thrombocytosis, erythrocytosis. But kidney cancer is an interesting tumor. It can present in almost any way. I've seen an individual present with a single metastasis to the big toe. And we as urologists consider kidney cancer as the great imitator, a bit like tuberculosis used to be or lupus. It can present with almost any kind of symptom. Kidney cancers are often asymptomatic, and they can be found, we hope, serendipitously. Sometimes on abdominal ultrasound for gallstones, sometimes with, for example, a CT of the lungs done for another reason, and the CT cuts through the kidneys and you find serendipitously a solid renal mass. There's a huge difference if they're found serendipitously, and as you see here from this graphic, the tumors that are found serendipitously, which are in the green, this is the survival. Survival is dramatically improved if you find them by accident as opposed to tumors that are found based on symptoms. If you have symptoms, your 5-year survival is only 30%. If your kidney cancer is found by accident, by CT or ultrasound, the 5-year survival is 95% or greater. Here is a more recent update from our series at University Hospital here in San Antonio. And the original graph that I showed you was from about 15 years ago when we published it. We looked at it again, and the differences persist. Dramatic difference if it's found serendipitously. Imaging studies for solid renal mass include an IVP that would show distortion of the collecting system. An ultrasound, as you see here on the left side of your screen, the stars surround a solid mass that's in looking at the kidneys. Many of my colleagues will tell me that these ultrasounds look like a weather map, a rainstorm over Hondo, as we say, but nevertheless, trust me, that shows a solid mass. On the right side, however, is another example, and this looks more like a cyst, but actually is a tumor. CT is the best study to look at this. Here you see a tumor in a solitary kidney on the left side. This individual actually has von Hippel-Lindau, and so you see there are two tumors, one on the posterior aspect of the kidney, one laterally, and actually there's a small one on the top side more medially that also represents a tumor. If it's solid, it's a cancer until proven otherwise. If you happen to see fat in it, it may be an angiomyolipoma, which is a benign lesion. And if it's of water density and the clear outline of it, it's a cyst and of no concern. We can image these quite well. We can do CT reconstructions, as you see here, the two kidneys, showing the ureters and the bladder as well, if necessary, and plan for treatment. We don't biopsy solid renal masses, and the reason for that is that you can miss the tumor and give yourself a false sense of security. You can seed it, although that's uncommon, but more importantly than that is a solid renal mass is a kidney cancer, until proven otherwise. In fact, 95% plus of the time, that solid renal mass is a kidney cancer. Staging is best with a CT scan, looking for example, enlarged lymph nodes. Alkaline phosphatase can indicate the presence of bony metastases, prompting a bone scan. But generally speaking, if you find it serendipitously, most of the time it's confined to the kidney. You do want to get a chest CT or a chest X-ray to rule out metastases. The only effective treatment for kidney cancer at this point in time is removing the tumor. It used to be that you had to take out the whole kidney, but if you find it early enough, you can take out just the tumor. And this is a solitary kidney, as you see here, with von Hippel-Lindau, that little kind of reddish appearing patch in the midline and the white little spot on the other side were tumors that were taken out. You see the little cyst, little tiny cyst on the top side above the red patch. That is a cyst that is potentially pre-malignant, and so that's taken off at the same time. And a partial nephrectomy, preserving the kidney itself, is an excellent option. Another way of doing it, taking kidneys out, which we do extensively today, is laparoscopically. You can do it, as you see on the right-hand side, either hand-assisted with a laparoscope, or you can do it strictly with laparoscopic instruments and brought the kidney specimen out through a very small incision. Partial nephrectomy we generally reserve to relatively small tumors, but we've been so effective with this that we've been actually increasing the indications, because obviously if you have a choice, especially if you have other comorbidities, for example diabetes, where there's a potential risk of loss of renal function, you want to have as much kidney parenchyma as possible. If metastatic disease is present, immunotherapy is the treatment of choice. And it appears from a randomized clinical trial that we completed a couple of years ago that if you have metastatic disease and if you plan on giving immunotherapy, for example, interleukin-2 or interferon, taking the kidney out in advance significantly improves survival. Let's transition now to bladder cancer, which is the second most common tumor that we see in individuals today. Bladder cancer is extremely common. Take-home message, person comes to see you, said, I had blood in my urine, and you ask them, did it burn, did it hurt? Nope. If the lights had been off, would you have noticed any difference? That is a bladder tumor until proven otherwise, if that individual has no symptoms. Do not treat with antibiotics, because most commonly it's a bladder tumor, and what will happen is the bleeding stops, and the individual feels reassured, and we've given the individual some antibiotics, and we take credit for it, and the individual goes home. The bladder tumor continues to grow, doesn't bleed, invades the muscle, spreads, and we've lost our window of opportunity. So painless, gross hematuria, till proven otherwise, is a bladder tumor. It's the second most common urologic malignancy. It's about 2% of all tumors. 50,000 new cases per year. Remember, kidney cancer about 30,000. 95% arise from the lining of the bladder, which are called transitional cells, but sometimes they can be adeno or glandular forming or squamous cell carcinomas. 80% are superficial or curable with resection alone at diagnosis, and about 50 to 80% will suffer recurrence. 20% will present initially with invasive cancer, and 50% of these will have metastases at presentation. What causes bladder cancer? Well, aniline dyes, aromatic amines, chemicals associated with the dye industry, the petroleum industry can cause it. But in this wonderfully developed nation where we have made cigarettes available for everyone, it is the predominant cause. And once upon a time, there used to be a substantial difference between men and women. I show you a Virginia Slims ad taken off the net that shows you've come a long way, baby, and yes, indeed, we're equilibrating our rate of bladder cancer by allowing everyone else to smoke. So here's another Slims ad. The point being is that if you see somebody who's a smoker, by telling them to stop smoking and being successful in doing so, you can actually reduce not just the risk of coronary artery disease, cerebral vascular disease, hypertension, and so forth, but you can also reduce the risk of bladder cancer. There are less common etiologies. Schistosomiasis in Egypt, which is due to invasion of a fluke into the blood system and into the pelvis, can cause squamous cell carcinoma. It's actually one of the most common cancers in tributaries of the Nile. And so if an individual moves to the United States from Egypt, comes in with gross hematuria, you have to be concerned about that. Fortunately, we don't see that in the United States. But more commonly, the same kind of cause for that, if you see somebody, for example, in a nursing home or a spinal cord injury center, a chronic indwelling Foley catheter puts an individual at higher risk of bladder cancer. So you see a Foley catheter, it's been in place for a long period of time, and gross hematuria occurs. You have to ask yourself the question, is there a bladder cancer? And so referral to your urologist for cystoscopy or for cytologic examination of the bladder specimen is a good idea under those circumstances. Pelvic radiation therapy, as well as treatment with a drug called Cytoxan, cyclophosphamide. The metabolite of that is something called acrolein and can increase the risk of bladder cancer. Several different kinds. Carcinoma in situ is a flat and it's poorly differentiated. It's a bad kind of cancer to have. More commonly than that, we see something that looks like a sea anemone, as you see here on the right-hand side. Superficial tumors that grow papillary nature. If a colonoscopist was looking at this in the colon, he'd say it's a colon polyp. Small percentage of these will invade the muscle, and it's important to stage these properly. And these superficial tumors can sometimes be multiple. The pathology of these, the carcinoma in situs, are flat and poorly differentiated. But the superficial tumors tend to be low-grade and papillary, and very small percentages will invade the muscle. Invasive tumors tend to be of higher grade. Here's you see a staging diagram. Here the circle, as you see, is not drawn to scale, but as you see, the lining of the bladder is the innermost aspect, and our stage goes up as it invades the muscle. As it begins to invade the muscle, the higher the likelihood that it will hop into a lymphatic, spread to lymph nodes, and thus metastasize. And bladder cancer that has invaded the muscle has a very high likelihood of having metastasized. As I said, the presenting symptom is gross. When I say gross, means you can see it, not under a microscope. Gross, painless hematuria, 80% of the time. Occasionally it'll be intermittent, but occasionally in about a third of the patients, the patient comes to see you and says, I have urgency, I have frequency of urination, and what you'll do is you'll say, oh, it's a bladder infection. You see a little bit of blood under the microscope, and it's a fairly common thing to see in individuals with bladder cancer, some irritative symptoms, and so you'll treat them with antibiotics, and they'll get better for a while, get worse for a while. You think it's recurrent infections, but the urine will always be sterile. Under those circumstances, always consider the possibility of a superficial bladder tumor, for example, carcinoma in situ. And frequently, that's your window of opportunity to make a diagnosis. On IVP, as you can see here, you'll see a filling defect. On the right-hand side of both of these films is that papillary bladder tumor that's indenting the bladder. Here is a papillary tumor on the right lateral wall, which is on your left, that's indenting the bladder. Here again is this cystoscopy, which then makes the diagnosis showing this papillary bladder tumor. And then you stage it with a transurethral resection, which means we scrape out the tumor and go into the muscle of the bladder to see if it's invaded the muscle, and also obtain a CT scan. As you see here on your left-hand side, you see that eroding lesion into the bladder that is clearly through the muscle, and actually you begin to almost see some enlarged lymphatics down below that posteriorly. Here is a tumor on the posterior wall of the bladder. You see that it's very thickened. The bladder is the midline structure with a darker area in the midline. You see how the posterior aspect, which is on the bottom, is thicker. The treatment for bladder cancer, superficial tumors, we scrape them out, but there's a 70% chance that these individuals will recur. So if you see a patient who's on his review of systems or his past medical history says, I've had a bladder tumor, the first question is, when's the last time you went to see your urologist? Because not infrequently the person who's had a bladder tumor who's been detected is scheduled for a repeat cystoscopy 3 months later, and sometimes they disappear. Come back 2 to 3 years later, gross hematuria. What do they have? They have a muscle invasive bladder cancer that's treated tremendously differently. So 70% of these individuals will have a recurrence, and what we have to do is to continuously keep an eye on the lining of their bladder to make sure that if you find the recurrence, you treat it promptly, resect it, and take care of it. If they develop multiple recurrences, we could put medications into the bladder, for example, BCG or mitomycin C, put in the bladder, directly toxic against the bladder tumors. If the tumor invades the muscle of the bladder, the treatment changes dramatically. That's why it's so key to find these early. Radical cystectomy, which means removing the bladder, is the treatment of choice, because if you don't remove the whole bladder, there's a very high likelihood of recurrence, and if it recurs and goes outside the bladder, 99 times out of 100, the individual, if he lives long enough, will die from bladder cancer, and that is absolutely unacceptable. We can divert the urine with a conduit, which brings the urine out to a skin, or what's called a continent diversion. We can make them a new bladder. The 5-year overall survival, if you see an invasive bladder tumor, nevertheless is only 50 to 60%, and that's why the best survival occurs if it's diagnosed early. This is the process of removing the bladder in a female patient. You see the uterus posteriorly, the bladder is removed in that fashion. This is what a conduit looks like, the 2 kidneys, the 2 ureters coming down, and a segment of bowel brought out to the skin. Obviously, we'd prefer to make the individual continent so they're not having to wear a bag. One of the early methods was something called an Indiana pouch, or multiple iterations of this, which we manufacture a new bladder out of bowel, and the individual, you see the tube that's going into that white-filled pouch, the individual then catheterizes himself or herself every 4 to 6 hours to drain the pouch. Unfortunately, it doesn't drain completely, higher likelihood of stones, and so the newest way of doing it, and the best way in our hands, is what's called an orthotopic, which means you make a new bladder, you hook it back up to the urethra. If necessary, you reconstruct the urethra, and so the individual voids normally. Here's an example of making a bladder out of ileum. You see the bowel that's made there. Here's our team that's actually making that. And then finally, this is how it looks like initially, but then immediately afterwards, within a few weeks, the individual's bladder, as you see here on the cystogram on the right-hand side, On the left-hand side is a relatively normal bladder. On the right-hand side is a new bladder made out of bowel. The individual voids to completion. We used to think that there was a higher likelihood of urinary incontinence, for example, in women than in men, because the sphincter mechanism is much more developed in men. We were concerned that when we moved this into women, there would be a risk of incontinence. Turns out, paradoxically, there's better continence in women than in men, and so we offer a continent diversion to virtually any individual as long as they do not have disease that's actually progressing into the urethra. Just briefly, with regards to cancer of the renal, pelvis, and ureter, it's relatively uncommon. These are the same kind of tumors that develop in the bladder, but they actually arise in the lining of the ureter or the renal pelvis. Just like the bladder, the majority of transitional cell carcinomas, many are papillary, which means that they grow into the tube of the ureter or into the renal pelvis, but they spread in the same manner. Here, maybe a little difficult to see, but you see the top calyx in this kidney. The large area of white is the renal pelvis, and that very irregular calyx up above that is a papillary transitional cell carcinoma. This is a retrograde pyelogram where we look into the bladder with a scope and put a small tube into the ureter. Put in contrast, and you see those two black areas in the distal ureter represent ureteral tumors. The treatment for these, we take out the distal ureter if that's the only part that's involved, with a ureterectomy and ureteral reimplant. If it's higher, you have to take out the whole kidney and a cuff of the bladder. And with that, it's generally curable, again, if you find it in time. So, the bottom line, what are the pearls from this morning's first presentation on genitourinary malignancies? Number one, consider and offer PSA screening in men with a greater than 10-year life expectancy. And again, remember, guy walks in who's 72, and he's in good health, he has a greater than 10-year life expectancy, and just so a person turns 70 does not mean that you should stop offering PSA screening. The average for 10-year life expectancy for the average person is 77 to 78. Let me just kind of say a parenthetical comment. An individual who's under 75, 76, 77, you get PSA screening, early detection of prostate cancer, to find tumor early and to cure it, prostate cancer early. Does that mean that a man over 77 cannot develop prostate cancer and die from his disease? No. And in fact, it's quite clear to those of us who take care of prostate cancer that if you find it, even if it's metastatic, but if you find it while it is asymptomatic, you can intervene with relatively minor interventions and prevent complications. Prostate cancer metastasizes to the bone, and when it does so, it can lead to catastrophic events like hip fractures, like paraplegia because of invasion of the spinal cord. And so even in an older individual, say for example an 80-year-old man who is in otherwise relatively good health, who has a strong family history of prostate cancer, or who you are trying to maintain in a high quality lifestyle, obtaining a PSA is not unreasonable under those circumstances, recognizing you're going to use it differently. For example, if the PSA in that an 82-year-old individual's 4, you're not going to biopsy that individual. On the other hand, that 82-year-old individual who is living at home, performance status of 0, activities of daily living, continues to drive, to take care of his spouse takes care of him, high quality of life, identifying a advanced prostate cancer in that individual could allow, for example, hormonal therapy. And it's very clear that hormonal therapy, if given early, substantially reduces the risk of catastrophic events. And I've seen that an individual who's living at home, high quality of life, enjoying life, has a sudden impact of a prostate cancer catastrophic event, moves from a high quality of lifestyle into a care facility that leads to other problems at home and dramatic reductions in quality of life. So, whereas the cutoff should be with a 10-year life expectancy with the concept of early detection, intervention for cure, it's not unreasonable, recognizing your target is different, getting a PSA or at least asking the question, might prostate cancer be present in an individual who is actually older of age. And it requires a little bit of conversation with the individual about his expectations. Further take-home messages: examine the testis. Seen incredible number of times where that's not done on admission, not done on routine physical examination. It's a simple test. It's a simple test. It's actually a lot easier than auscultating the heart. Gross hematuria is a bladder cancer till proven otherwise. Second most common cause is a kidney cancer. Irritative voiding symptoms: if your culture is negative, remember it could be a bladder cancer. Don't ever forget that bladder cancer can cause irritative voiding symptoms, and it's not always painless. If you receive a report of a solid mass in the kidney, it's a kidney cancer till proven otherwise, and the biologic growth rate of kidney cancer is substantially faster than many other tumors and really requires intervention. Now, that's been a soup to nuts review of genitourinary oncology. It doesn't include everything. But I hope it gives you some take-home messages and some pearls that will be useful to you. Thank you very much.
Since this day and time, most people are caught up in the real primary juice, not copy, real primary juice, does marbles. Does that interfere with in any way or early detection?
Cranberry juice. The question is, does cranberry juice interfere at all in early detection of...
So many people, when they either the kidney or the bladder,
yes, sir,
they grab it and
right.
may not go.
Yes, sir. Cranberry juice is actually a wonderful source of vitamin C, and it acidifies the urine. And so, to my knowledge, I don't know there have been, I'm a clinical trialist, and so I'm a natural skeptic. I don't believe anything unless we've actually conducted the study. I don't think that there may have been. I don't think that there are any clinical trials. However, you see many an individual who takes cranberry juice and finds that their urinary symptoms are improved. And actually, because it acidifies the urine, and an acid urine is an environment that it's harder for bacteria to grow in, it may actually reduce the risk of things like urine infections. It may help with some conditions. On the opposite, and I'll get to your answer to your question in just a second. On the opposite side, there are some individuals whose urinary symptoms are exacerbated, made worse by acid in the urine. There's actually some over-the-counter products that you could buy that reduce the amount of acid in the urine. So it becomes a very individual thing. Now, with regards to detection of cancer, no impact, to my knowledge. In medicine, you never say always and you never say never, but to my knowledge, and I can't think of a reason why it would interfere with...
The only thing I was thinking that their symptom might be alleviated temporarily.
That's a,
not
yes, sir. That's a good point. Conceivably, there are some things that you can take that alleviate urinary symptoms. There are medications that we give that prevent the bladder from being hyperactive, and there are pain medications and so forth. So those can. However, cranberry juice and natural products that you can buy, I think, would be unlikely to alleviate the symptoms, for example, of bladder cancer. But the bottom line is, if you have symptoms and they persist, whatever they are, the right answer is come and see us or see a urologist.
And one other question, you just barely touched on it, but one of the patients having a PSA of under 1, and yet you detected some way cancer. How did you do that?
A rectal examination. And also it's...
What caused you to even do it?
If someone comes to see us, I guess it's like a cardiologist. Do they just listen? Do they just get an EKG? Of course not. They listen to the heart. They look at the neck veins. They look at the lower extremities. A urologist, when you're looking at somebody to determine if they have a urologic problem, you take in the whole person. And part of that is things like family history. So if an individual has, I've seen individuals who come in who say, I'm here for my first prostate checkup. Okay, 50 years old. Any family history? Yes. Every single member of my family on the male side has died of prostate cancer before the age of 50. Seen it. Individuals 50 years of age. That's somebody that you start 40. That's also somebody that if you, rectal examination is a very complex test. And actually, I continue to learn, I continue to get feedback because I know what my examination and what the prostate looks like, feels like, the biopsy looks like as well. It's not clear to me that a rectal examination looking for cancer, that everybody has the same degree of experience. I mean, if you look at, for example, individuals who are taken care of by groups of doctors who, or healthcare professionals who don't routinely do prostate biopsies, for example. My bet is that their threshold for calling something abnormal is significantly lower, greater than our threshold for calling something abnormal. So in an individual with a PSA less than 1, how do we find cancer? Was suspicious of it. Rectal examination, sometimes it's a grossly abnormal rectal examination, sometimes it's a subtle finding. And you just say, I wonder if. And my crystal ball suggests to me that I suspect that we're going to be using lower cutoff levels of PSA, and we in our research efforts, we're actually trying to find better tumor markers. PSA is the best tumor marker there is for any cancer anywhere for early detection, but we need better ones, and so we're in the process, hot pursuit of better studies than PSA.
The old gut level.
Exactly. If you're suspicious, you've got to be worried about it. Yes, sir.